Hello, and welcome to the symplr Education Series webcast. Today's webcast is titled Advanced Concepts in Credentialing, Recredentialing, and Privileging with guest speaker Kathy Matzka. Next slide. This presentation is NAM certified and presented to you by symplr, Compliance and Credentialing for Healthcare. Next slide. We are so honored to have Ms. Kathy Matzka as our speaker this month. She is a speaker, consultant, and a writer with 30 years experience in credentialing, privileging, and medical staff services. She holds certification by the NAMS Association of Medical Staff Services in both medical staff management and provider credentialing, and is one of the first recipients of the NAMS Fellow designation. If you have any questions, please submit them via the chat box on the right side of your screen. I'm sure many of you know Ms. Kathy, and I'd love to hand it over to her now.
All right, well, thank you very much. It's nice being with you again. So what we're going to cover today are some of those more difficult concepts that we have to address as far as credentialing and privileging. We're going to look at some hospital regulations and how to document competency, and those low and no volume practitioners, those people who practically never show up or maybe never show up, and how do you handle them? And also, how do you handle requests for new procedures? When somebody comes to your facility and they're requesting to do a procedure that no one has ever done at your facility, so how do you handle that? So these are some more advanced topics to kind of build on our past presentation that we did on basic credentialing. So first off, let's just take a look at some of the CMS regulations. The Medicare conditions of participations for both hospitals and critical access hospitals require that you evaluate certain things when somebody requests privileges. So within a hospital, those criteria that are looked at, that are required to be evaluated for each individual who requests privileges, are their character, their competence, their training, experience, and judgment. So it's pretty easy to get things like documentation of licensure or find out where they did their training, but some of these other things like competence and judgment and experience, these are a little bit sometimes more difficult to get. So we're going to cover some of those areas. So also, the CMS regulations require in the interpretive guidelines that the credentials that are evaluated and examined by each hospital for each practitioner is that there has to be a request for clinical privileges. This is usually our privilege form. It's addressed in that way. We have to have evidence of that they have a current license, and when you look at CMS regulations, they don't require that you verify every license from every state. They do require that you verify current licensure for the state where they're going to be providing care to your patients. Also, evidence of professional education and their training, their documented experience, and then they require those supporting references of competence. So these are what we consider our pure recommendations. So this is where everything kind of flows down from. You see the CMS regulations have specific requirements that you evaluate these things, and then you see these same things flow down into Joint Commission and HFAP and DNV standards, because those accreditors' standards have to meet the minimum requirements of the CMS regs. So it all starts with the CMS regs. So let's take a look at some of these more difficult things to document. So competency, what is competence? Well, it's the ability to do a particular activity to a prescribed standard or a desirable outcome. So that's what we want to have. We want our medical staff and our practitioners who doing things to meet the minimum requirements or minimum standards that have been set by the hospital or specialty groups or so forth. And we want, of course, a desirable outcome. We want our patients to do well. We want them to get better. And this is based upon practitioner's knowledge, traits, skills, and abilities. Now, those of you who might have an HR background might be familiar with the KSA's knowledge, skills, and abilities, but there are also traits that make someone better, do things better. You know, you may have someone who, you know, is more outgoing and has better patient relation skills and so forth, and that can also affect someone's competency. Now, the Accreditation Council for Graduate Medical Education and the American Board of Medical Specialties got together some years back, and they put together what they call the core competencies. And these core competencies are utilized by ACGME, medical schools, and training programs, and they structure those training programs around these core competencies, as well as the specialty boards that are ABMS member boards also structure their requirements for board certification around these core competencies. So it just makes perfect sense since this is how medicine is evaluating itself, that this is also the way within a hospital the medical staff would evaluate itself. So these things that are included in core competencies are a practitioner's medical knowledge, their patient care and procedural skills, their system-based practice, how they're integrating into the, you know, the system and working together with the system, their professionalism, practice-based learning and improvement, that continuous improvement based upon their practice, and interpersonal and communication skills. All of these are important aspects of competency that should be evaluated for practitioners within a facility. Now, some people, if your bylaws may include language for provisional appointment. Back in the old days, all bylaws included a requirement for a provisional period of appointment. You would just see that as normal language that you would see. And during a provisional period of appointment, somebody would initially come on staff, and you wouldn't put them automatically on your active staff. Instead, you would put them into a provisional period of appointment. And during that time, their clinical work would be looked at and evaluated, and it may include some proctorship requirements, some monitoring, chart reviews might be done. But in order to do this, you of course have to have adequate volume. People have to actually be doing work to be able to evaluate them during this provisional period of appointment. Well, we kind of got away from provisional period of appointment, although I do see it in some bylaws, and that's perfectly appropriate. But as our QA/PI processes within a hospital started becoming more sophisticated, and we started doing more ongoing monitoring and having the ability to pull data and see how people are doing and do comparisons, that a lot of facilities got away from a provisional period of appointment and would just go with maybe an active staff or an associate staff or consulting staff, something like that. But some people still have provisional period of appointment, and that is one way that hospitals and medical staffs will monitor competency for new practitioners just coming on. The language that we see now is professional practice evaluation. There's focused and ongoing professional practice evaluation. The Joint Commission first came up with this concept of focused professional practice evaluation, and the HFAP accreditation has mirrored their language. It's almost identical language as in regards to FPPE. So what the concept of this is that everybody who initially request privileges, whether they are someone who is a new practitioner who has never been on your staff before, or someone who's currently on your staff and they're requesting additional privileges. Any initial requested privileges should be subject to this period of focused evaluation. Also, if someone there's identified some kind of an issue, maybe through your QA/PI process or some kind of a reporting mechanism, there's some kind of an issue that has been identified, and that issue is felt that it could affect safe and high quality patient care, that may be another time where you may want to bump somebody into a period of focused professional practice evaluation. The FPPE plan that you have should identify triggers, so that if somebody meets a trigger, it may be a benchmark that is exceeded, or something, or even a single incident report might trigger an event. So these things should be identified in an FPPE plan, and then it's used to determine, what are we going to do about this? How do we bump them into this FPPE, and what are we going to start looking at? There's also language that you see with Joint Commission and HFAP of OPPE, which is our ongoing professional practice evaluation. And these are the ongoing indicators that are being collected. And this information is used to determine whether or not somebody's going to be able to keep their current privileges, or revisions going to be needed, or maybe even privileges need to be revoked. It has to be defined as a clearly defined process, and that each person, each practitioner's professional practice needs to be evaluated as part of this ongoing professional practice evaluation. The type of data that is collected within the medical staff, it has to be for Joint Commission accredited facilities, their individual departments. So for example, your OB department might define specific indicators, and then those indicators might be something like, VBAC rates or C-section rates, or other type of indicators, inductions or whatever. And then that department identifies what kind of things it wants to collect for those people who are working in that department. And then those indicators are then approved by the medical staff. For an HFAP accredited hospital, the standards just say that the medical staff determines what kind of data is collected. But once that information is collected, it's used to determine whether or not somebody's going to be able to keep their privileges. Are they going to, we look at all this information, the medical staff evaluates it and compares it to what they're currently doing at the facility, and says, gosh, is this person doing the things that they are have requested to do on their privilege form, and are they doing them well, or are there any kind of problems? So each time this OPPE data is evaluated, the medical staff should determine if there's any kind of an issue that would require any kind of an action regarding those clinical privileges of those practitioners. Now, there's a number of ways of doing this. There's a lot of different ways of doing OPPE and FPPE, but typically we see a lot of it done through chart review. Now that we have we have electronic health records, we can either do it retrospectively, or we could even have a process where a department chair may even evaluate medical records for patients that are currently in-house for a new practitioner. So a periodic chart review is one way of doing some OPPE, FPPE. Having direct observation or proctorship, you may have a case where it's a brand new procedure, nobody's ever done it at your facility before, and you may have to bring in a proctor to evaluate the first couple cases to make sure that they're being done appropriately. There also, if there's a problem that may be identified, for example, in your evaluating surgical incidents, and you find that there's somebody that has a high rate of unplanned repair, injury, lacerations, then that might be something, it might be where your medical staff might look at it and say, okay, they've exceeded our benchmark. So we're going to do a focused professional practice evaluation, and we're going to have, another general surgeon watch this person during their next 3 surgeries and see how they're doing. So that, those are just possible ways of doing it. Also, the monitoring of diagnostic and treatment techniques. This is how we, do our diagnosis-related evaluations. You might look at, pneumonias or UTIs or whatever, and evaluate those. And also, I like that they added discussion with other individuals involved in the care of each patient. So you can also talk to people, find out how people are doing, and appropriately document that. So as long as it's done within the concept of peer review, you want to keep it within that peer review function so that it's protected by your laws that protect the peer review. So for example, you may have a new surgeon that comes on staff, and part of your FPPE plan might be that the department chairman goes to the operating room and talks with the director of surgical services and asks the nursing, director, how is this person doing? Do they know their way around the OR? Are they showing up on time for surgeries? But keep in mind that if that's something that you're going to be doing, make sure that you do it with it, identify that as part of your peer review process, and that it's documented appropriately as part of the peer review process. So you can talk to other physicians who are involved in the care of the patient. All of that is a good way of doing OPPE and FPPE. When you're documenting those recommendations and actions, it's a good idea to make sure that things are documented during each step of the process. I see it on a regular basis where there are medical staff minutes where there is an action taken, but there's nothing documenting the basis for the reasons for the recommendation or decision. That the minutes are just maybe something that says the following people were approved, and it just lists some names, and it doesn't really say too much about it. So having good documentation in your meeting minutes is really important, making sure that you have documentation of actions and recommendations made in each step of the process. So for example, if your process is that a department chairman signs off on something, and then it goes to the credentials committee, and then it goes to the MEC and up to the board, each step in that process should be documented in medical staff minutes, or some people might even use an approval form, and of course including the reasons for those recommendations or decisions. And I like to see medical staff minutes that include the same type of language that you see in your bylaws. So for example, if you look at your bylaws for your credentials committee, it's going to have some specific language in there about what the committee looked at, and what they're supposed to be looking at, and what they're supposed to document, and like the decision and the basis for the decisions. And you'll see this frequently, this boilerplate language in minutes. So it's a good idea to take a look at your minutes, see what your minutes say. Your bylaws, see what your bylaws say that the committee is supposed to do, and then document in your minutes that that's what the committee did. So using language similar to what you see on the screen, that the committee members review the applications, the supporting documentation, the department chairman's recommendations, and information received during the credentialing and privileging process. Based on this review, it's the committee's opinion that the following applicants meet the requirements for medical staff appointment, have documented appropriate education, training experience, current competency, clinical judgment, professionalism, and health status to perform the privileges requested, and so it was moved, seconded, and carried to recommend to the MEC approval of the following appointments and clinical privileges. So what you've got there is you've got everything that your medical staff minutes or your medical staff bylaws require. The committee. What did the committee look at? What is the basis for their opinion, and what is their recommendation? And then we've also documented these requirements that the CMS has, that you look at education, training, current competency, professionalism, and so forth. And all that's included in there. So it kind of ties it up really nice and clean, and shows that our committee looked at everything that the bylaws say that they're going to look at. And we also evaluated the requirements of the CMS regulations. So that way you have really clear language tying it all together, and showing that the committee really did look at these issues. Okay, let's switch gears now, and let's talk about how you deal with those low and no volume practitioners. With these, sometimes the people that we had that were the people that were constantly at our facility. They were the ones who were, attended all the medical staff meetings, those primary care doctors. You saw them all the time. They were coming by and stopping in the doctor's lounge, eating the candy out of your candy dish. And they were the people that you passed in the hallway every day. And now many of those people you just don't see anymore. So sometimes we have these people on our staff that for whatever reason they're just not there anymore. Sometimes it might be people who practice mostly or at another facility, and they're on your staff just in case they get a patient that wants to come to your hospital, but they really do everything at the hospital across town or in the next town. Sometimes people might be voluntarily limiting their practice. So if they if they decide that they're going to be cut back, maybe they're getting ready to retire and they've got somebody new in the office that's doing all the hospital care, but they don't really want to give up their privileges yet, so they're just voluntarily limiting their practice. And then there may be people whose practice is just office based. They are those people who only see patients in the office intentionally, and that's all that they want to do, and they have a hospitalist that takes care of all their hospital patients. Or they may be, the office itself may, the medical office may divide up the responsibilities and have a couple practitioners who do all the patients that are in the hospital, and you know, and then some people else, other practitioners in the office just see office clinic patients. So they may split that up. Then you might have people who just took some time off. You know, people took, you know, medical, family medical leave. Somebody who has a baby and they take off for a while, or have, you know, some kind of an illness. Sometimes people take off to take care of sick family members. Sometimes you have people who retired, decided they weren't going to work anymore, and then changed their mind and decided they wanted to come back to work. So all of these people are potentially these low or no volume practitioners. And remember, the CMS regs say we have to look at competency. We have to evaluate their experience and their competency. So it's really difficult to do when somebody's not doing anything at your facility. So with some things that we can do to help document that competency, we can get data from another organization or office to help us with defining, you know, what is a reasonable information that we can get from other places, and how will it also carry over to the type of patients that they're seeing at our facility. So if you're going to be getting data from another organization or maybe a practitioner office, you really need to have a policy and procedure that addresses that, and appropriate consent and release. I've also seen bylaws that have language that says that for any practitioner, especially low volume practitioners, that the practitioner will consent to the release of data from another facility where they're currently working. And so if you're looking at documenting ongoing professional practice evaluation, that isn't what OPPE is. Some people think that, oh, if I don't have any OPPE data, I can get information from another facility. That's not what ongoing professional practice evaluation is. Ongoing professional practice evaluation is only specific to your facility. But you can use information from another facility to supplement your own information that you've collected when you're recredentialing someone. But it will not, like I said, replace your own facility's requirement to do OPPE. Now, some people will get office data. They may ask the providers to give us, you know, a listing of your, you know, procedures that you've done in your clinic. And in some cases, this may be appropriate information, but in some cases it may not, because there are different kinds of patients that are treated in a clinic setting as opposed to an acute care setting like a hospital. There may be, though, doctors who have their own office, like an outpatient surgical suite attached to their clinic, and those types of procedures would be appropriate to be able to collect and evaluate if you're trying to just get numbers of procedures that someone has performed. But keep in mind that the things that they're doing in those offices and outpatient surgery centers may not be relevant to the more acute things that would require hospitalization. Now, if you don't have sufficient practitioner-specific data when you're recredentialing someone, the Joint Commission does allow you to use peer recommendations to fill in when you don't have that. So if you're a Joint Commission accredited hospital, if you're recredentialing someone in their low volume, you can use peer recommendations. Peer recommendations are, you know, when I speak of peer recommendations, I mean the letters that you send out to someone and ask them to complete an evaluation on a practitioner and send back. I'm not talking about the usual peer recommendations that you see when, you know, a committee of peers recommends someone or something like that. So these are the letters that we send out to people and ask them to document their competency and qualifications and so forth. So Joint Commission does allow that. Another thing to keep in mind is that you might want to consider, if you don't already have something like this, like an admit and follow privileges or refer and follow category. I've seen this done both ways. With admit and follow privileges, what happens is they will have the ability to admit a patient and follow that patient. So some hospitals will allow practitioners to admit someone, but then they directly turn that patient over to a hospitalist. It allows them to be able to do a direct admit from an office without having the patient go into the emergency department to get evaluated first. Or else I see refer and follow categories, and refer and follow categories are just where you have a practitioner who is only allowed to refer a patient to the hospital. So the patient comes to the hospital, hospitalist is taking over, but this doctor can still follow the patient. They can view the electronic record and so forth. If they want to stop in and see the patient, they can, but they don't really, they can't bill for their services, and they can't do any orders or anything like that. And those work out fine if you're referring to a hospitalist, but no privileges means that you do not have to focus on ongoing professional practice evaluation, because that only applies to privileges, not medical staff appointment. But if you would allow someone to have admitting privileges, then they would have to, that is considered a privilege, and so you would have to have evaluation of that appropriateness of those admission orders and whether or not that patient should have been admitted. And that's something that the hospitalist or whoever takes over for the patient can help you with that evaluation. Another thing to do for these low volume practitioners is ask them why they want to be on staff. Sometimes practice changes over time. People might initially want to do one type of practice and end up, going to another type of practice. They may think they're going to use the hospital, but then they don't. But the doctors don't usually complete these recredentialing forms. It's usually someone working in the office with them that is doing that for them. So they don't put a lot of time into thinking whether or not they really want to be on your medical staff. They'll just, have a stack of papers with signature stamps, and they just sign all the tabs where it says to sign, and that's pretty much all they'll do. So they may not put a lot of time into this, filling these applications out, so they really don't think about whether or not they really want to be on your staff. So it's a good idea, rather than just routinely sending these low volume or these no volume. If somebody hasn't done anything at your facility in 2 years, you might want to say, well, why, instead of giving you a recredentialing form, instead we're going to send you a letter saying, tell us why you want to be on our staff. And, ask them why we notice you haven't done anything here for 2 years. Can you tell us why do you really want to reapply for staff at privileges at this time? And then give them the opportunity to resign from the medical staff, or to allow their current medical staff appointment to just, run out and not get recredentialed. So you need to have something, though, that would be something, the letter needs to be addressed directly to the doctor, and for the doctor to answer this, so that the office assistants don't make the decision for them. So I've done this with several hospitals, and you always get some back saying, I resigned from the medical staff. I didn't even know I was on your medical staff, those types of things. So, ask them why they want to be on staff. In some cases, they may say, because the managed care organization requires me to have admitting privileges. If that's so, then you may want to contact your contracting department in your facility and ask them to, who the contact person is that, you're signing your contract with these managed care plans, and talk to them and ask them, do you really require admitting privileges? Because most managed care plans now require that you either have admitting privileges, or you have an agreement, an arrangement with someone else to take care of those admissions for you. So they may think that they have to have them, but they may not really require admitting privileges. You may need to, if you're going to do these different changes in language, you might need some new bylaws language. If you haven't revised your bylaws in the last few years, you may need some, some attention to those bylaws, because the way people are practicing medicine is different now than it used to be before. You had active and associate and maybe consulting staff and maybe some courtesy staff people. Well, now we've got hospitalists and telemedicine and other categories of practitioners that are working. So you may need to further define your staff categories, and you may also want to redefine prerogatives. So, for example, if you have an active staff and the active staff members are allowed to admit patients, and you may want to redefine what a patient contact is. So, for example, if you have a requirement for admitting at least 30 patients a year, you may want to say, let them admit or refer to a hospitalist 30 patients a year. And do you really want them not to? Because you want to be able to keep them on your active staff, because you want them to be able to participate in committees and be, as a medical staff leader and so forth. And if I was a physician and all of my patients were being admitted to your hospital, I would want to have a say so in whether or not they're, somebody, who's going to be voted as a medical staff leader. I'd be wanting to vote on bylaws and changes and so forth. So take a look at that, look at those thresholds for those categories. And some people also have what they just call an ambulatory or office-based category that they include in their bylaws as well. There may be some doctors who don't want to come to meetings, and they don't want to vote on bylaws. And so that might be their best option, is a category that allows that they can, still be a medical staff member, but not have privileges and be in this ambulatory or office-based category. Also, making sure that your bylaws include some language that defines a complete application as also data from another facility if you're a low or no volume practitioner. And another thing that you can do too is if you have somebody who just wants to be on your staff and they don't want to resign and they're really not doing much, you might want to consider either adding, if you don't already have one, or increasing your reapplication fee, because it's costing your facility money to keep these people on staff. It's costing your medical staff time and money to evaluate these people. And if they're not doing anything or admitting any patients to your facility or using your facility, it's just costing everybody. So that if they want to be on your staff, then they ought to be the one that are paying those fees. Okay, final topic we want to talk about is adding new procedures. So when somebody comes to you and wants a brand new procedure, the things that you need to consider is that when you're granting privileges, that you should only grant privileges based upon services that are currently provided at your facility or something that's planned to be provided in the really near future. So for example, you've decided you're going to be adding robotic surgery. You're buying the equipment, you've got the suite set up, you've got everything ready to go. You can, if everything's in the planning stage to do this, it's all been approved, then you can go ahead and develop those privileges for that robotic surgery. But if somebody just comes to you and says, I want privileges to do robotic surgery, and you have no intention of purchasing the equipment, then that you should not be processing a request for those privileges if you don't have the necessary equipment and trained staff to support those procedures that those people want to do. If your medical staff wants to add some kind of a new service like that, you also need to, your governing body will need to look at other things too, like are we going to have enough qualified physicians to support the service? Are we going, is there a medical need for this in our community? Is there, is there another hospital that's a big university hospital that's right next door that's already providing this? And so do we really need, does our community really need another, this service at our hospital? And are we going to have enough volume to support the program? So these are things that your governing body needs to take into consideration before adding a new service. Once the governing body approves that, then the medical staff should be providing input into that approval, and then you gather all the information from any specialty that's involved. If it's a service that crosses specialty lines and there may be more than one specialty that's doing it, find out what kind of programs other facilities are doing, Make sure that you look at any kind of specialty organizations to see if they have any guidelines and evaluate those. And you might need to have a multi-specialty committee to sit down and determine what the criteria is and come up with the best criteria that will be the same. And everybody who's doing the procedure needs to meet the same criteria. You can't have two separate types of criteria for two separate specialties. There should be one set of criteria for everyone who wants to do that procedure. And of course, while you're developing those procedures, you of course don't process requests for new privileges. You wait until that criteria is developed and approved before you do that. And when you're looking at it, your medical staff needs to determine who's going to be able to do it and what kind of training and experience is going to be required. Also, is there any other requirement, or is there going to be a requirement for training programs that you go to, continuing medical education? Are you going to say only board certified doctors can do this? Is there a specific vendor course that has to be attended in order to do it? Are you going to require peer recommendations? This is all, will you need to be proctored for that procedure? Sometimes the vendors themselves that are providing equipment will provide a proctor, or they will want you to have someone to come in and be proctored, to proctor someone. And then, of course, you need to determine how are we going to roll this into our QA/PI activities, make sure that things are being done well and in a high quality way. How are we going to do focused professional practice evaluation and roll this into our OPPE processes? And then, of course, we need to determine when somebody's requesting a new procedure, if there's a transference of skill. A transference of skill is when the same skills are required to do different types of procedures. So, if you can do procedure A, then you can do procedure B, because it takes the same type of skill. So you may not need to develop a whole different criteria if there's already a similar procedure that takes the same type of skills. If a physician hasn't done, a specific procedure, but has done another procedure where those skills would transfer over, then you can group these together. The laparoscopic procedures are a perfect example. When they first came out, we were doing lap choles, and then we started doing lap everything. So once all those laparoscopic procedures started coming out, we started grouping them together in categories that required the same type of skills. Of course, it's probably not going to apply to surgeries that require, more specialized skills, that are things that are not regularly performed or require, specific specialized equipment. After you get those people on, these new procedures going, and then, you need to determine indications for the procedure and try to evaluate and establish some expected complication rates and add that to your QA/PI, FPPE plan, and make sure you're monitoring for any kind of volume requirements. If if you have somebody new procedure and you say that you have to do a certain number of procedures, then you need to make, in order to maintain those privileges, you need to make sure that you're keeping up with those volume requirements and that they've established those appropriately. Okay, I think it's time now for a quick word from symplr. Callie, would you like to take over? Rachel?
Yes, I would love to. I would like to introduce Rachel, my colleague, who is going to talk about symplr and how it applies to this topic. So, Rachel, it's all you.
Awesome. So, I see I have the screen. Give me one sec to get everything queued here.
All you, first slide, dear.
Okay, that's fine. All right, so again, thank you so much for taking time out of your schedule to meet with us. My name is Rachel. I've been a trainer, and now I'm also the regional sales manager for the South for all of our Cactus and symplr clients. So we're really excited to have your time here. And thank you again, Kathy, for providing such a wealth of information. I want to make sure I show you just a few solutions that can help you apply and optimize all the great information and recommendations that she's given us today. Many of our clients use Cactus as their source of truth, and here at symplr, we're dedicated to offering a full cycle provider management solution that can ease the task of sharing data amongst previously disparate systems and departments So let's do a quick overview of some of the tools we've developed to help you achieve your goals. I'm going to go a little fast here to allow time for questions for Kathy, but just want to make sure you can reach out to us at symplr.com, and we're more than happy to schedule a demo or do a deeper dive if you have any questions about the information we're going to talk about here. Okay, I'm ready for our next slide. Let's dive in and talk about privileging. So she mentioned some of the hiccups and problems with privileging. Part of it is content, right? And also looking at who has control over that privileging content. So the new way that we're doing this is you actually have two different privileging modes. You can have it set up so that you do, privileging however you want to today, but you could also leverage our privileging content and library to share that information. We'll talk about it a little bit on the next slide, but we've also got real-time privilege lookup for nurses on the floor who need to understand what kind of procedures providers are allowed to do. And now with corporate privileging, you can establish one entity as maybe corporate and establish rules to copy privileging over from facility to facility, things you couldn't do previously in Cactus. And we all know bylaws change. So you can actually leverage the versioning functionality to ensure you publish those privileges when you're ready. Let's go to the next slide here. So our privileging library is the biggest change. With that, we're going to have over 250 specialties. These are actually tools that clients from the MedKinetics and symplr side have had access to for a long time. We have a staff that works constantly to update these privileges, keep them up to date. We work with several different sources. I think we only have a few listed here, but it's really closer to about 40 to gather all that information. And along with our new privileging, we call it Cactus Privileging Plus, but along with that new feature, we also include your ICD, CPT codes. We all know the new codes for 11 are going to come out soon, and they're huge, so that data will already be in the system for you. That also ties in with our next product here. So we can also leverage the peer review system to collect some of the information that happens during the peer review process. Now, we actually, you can go to the next slide, there we go. So we actually have, powerful peer review workflow automation. We have a repeatable, transparent, and defendable process. The primary goal behind a tool like this is how do you demonstrate that your bylaws were followed? So you have a peer review process. We want to make sure that you can complete your cases, any documentation around that, pass it around to different departments that might need to provide input on that. This can be leveraged for the FPPE process as well as peer review. And then also very, very powerful reporting that's going to be talked about on the next few slides here. But if you go to the next one, you can kind of see our peer review tool was actually developed with Horty Springer. So they had the option to choose from a couple different vendors, and they actually decided to work with us to build this quite some time ago. So it's been around for years. We actually follow a process that was developed with them in their system. So excited to share that with you. What we do is we actually collect and capture your specific process. So we sit down and we actually work with you to develop what your workflow process should be. And this is a living, breathing document that's connected to the program. So we can help demonstrate how and when these actual bylaws and your review process is followed. All of that information, privileging, peer review, feeds into our last tool here, which is professional practice reporting. Now, in professional practice reporting, we're looking at leveraging your different systems that we know collect that information and creating reports that you can utilize throughout your organization. So it combines your EMR, billing data, provider privileging database to build a complete history of the provider's activity. That way you can really see how often is Dr. Abbott actually performing that procedure. And if she's not performing it, do we need to come back around and maybe have some proctoring or something like that to find out why she's not as comfortable with that skill anymore. It also enables comprehensive reporting through OPPE and FPPE. And we also can perform peer comparisons and benchmarking to kind of see throughout the organization, where is this particular provider lying? We also have a tool, iCommittee, that can be used to sort of leverage and capture, any sort of review process that's happening online, sort of a more prettier graphical way of showing that information. But the last thing I wanted to show you is a sample of that OPPE report and the data that comes with it. So again, going really fast here to save time, We can do a deeper dive if you'd like to do a demo, let us know. But for example, with Dr. Myers here, we can not just see information about where her department and specialty lies, but we can see based on what's coming in from Epic or our EMR tool, you know, how many times is she actually performing certain procedures? If there's certain procedures she's doing more than others, you know, is that something we might want to look closely at? You can dive in again and compare her to other providers against the organization and find out a little bit more detail about what's happening within the system there. So I'm going to go ahead and turn it back over to Kathy for her portion with any questions. But again, please reach out to us, symplr.com, with any questions about demos. We'd be happy to assist you.
Thank you for that.
Yes, thank you so much. I would like to say that you can now submit your questions via the chat box located on the right side of your screen to have them answered by Ms. Kathy in our Q&A portion. I would also like to say that you will be receiving the recording of this video to view and a downloadable PDF of the slides from communications@symplr.com soon. That is also the address that will send out your NAM certificate. So if you would like to ensure that you get both of those emails, please add us to your address book so that we are not marked by your spam filter. Again, that is communications@symplr.com. All right, Ms. Kathy, the first question I have is, during a state survey, the auditor stated that the core privileges we were using didn't meet CMS standards for privileging, but did not provide any specific reasons why. Are you aware of any reason that core privileges would not meet CMS regulations?
I am not. I can remember in, about 5 years ago when they revised the standards, they came up with this language that said it cannot be assumed that everyone can perform every task, privilege, procedure that's listed for a specific category of practitioner, and that the ability to do each one of those tasks has to be evaluated. I'm paraphrasing, but that's directly out of the interpretive guidelines. When that language came out, some people were saying, oh my gosh, they're not allowing core privileges anymore, because core privileges are, you know, you define the person's, the requirements that you have to be, you know, board certified, you can have this education and training, and then if so, then you get to do everything on the list. Well, the core privilege form in itself is not a way, is an appropriate way of delineating the privileges, but you still have to assess their ability to do those things that are on that list. So the way you list it, it doesn't make any difference if you list it as a core or if you list it as a laundry list that they have to tick off each place that they've done. You have to individually assess their ability to do it. I have not heard of any CMS surveyors that were citing people for using a core privilege form, as long as it had the criteria and you were evaluating their ability to do those things that are on that form. So if you were told that, that's the first that I've heard of someone being told that they couldn't use a core privilege form. I think core privilege forms are widely accepted across the country, and many hospitals use them.
All right, thank you, ma'am. Next question is, how do you monitor new dentists? Our dentists never have enough hospital volume to take them off the FPPE, so we just take them off after 3 months.
Well, I mean, you can do something simple like a case review. If you're doing you can have after their first review, their first 3 or 5 charts, and have your medical staff evaluate those first charts and see if there's any kind of problems. That can be your focused evaluation. You can talk to people in the OR and ask them, are they showing up on time? Are they doing everything okay? Are they, keeping up with, sterile techniques, those types of things. You just need to have some mechanism for doing it. Chart review seems to be like the #1 way that people do FPPE for most providers. If you have, they identify what they're going to look at, and they just do a retrospective chart reviews.
All right, thank you, ma'am. Next question. What category should a low volume physician be in, but they are serving on committee assignments?
Well, if they're a low volume practitioner and they're serving on committee assignments and you want to keep them on that committee, then you have to make it work for a category for you. If they're low volume, then I guess it depends on how low they are. If they're not doing anything, then you just need to look at what your categories allow. And if you have them on a category that, if like say your active staff category says that they have to have X number of admissions in order to be on active staff, then you might want to consider doing away with those minimum requirements if you want to keep that person on active staff, or else if they're, if they're a low volume, but they're, or else if they're in a different category, say like a courtesy staff or something like that, or an associate staff, then include letting those people vote or serve on committees. It's all going to be in the way that your bylaws are worded, but your medical staff can word those bylaws any way they want, as far as those categories. CMS just says that you have to define it. They don't say, exactly what you got to do. You can, medical staff can define what they feel is appropriate categories and who fits in those.
All right, fabulous. Next question. What about academic medical setting? Most of the departments require all of their staff to have privileges whether or not they come here. They never want to give it up. How should we handle these?
Well, and that's, again, it's hard to document competency for someone who doesn't do anything there. If you're Joint Commission accredited or otherwise, you may want to do it with peer recommendations. You may want to have, if it's the department chair of those academic departments, if they know them personally and can attest that they're competent and qualified. There just needs to be some mechanism for, you can't just keep appointing someone over and over and over again without having any kind of data and no recommendations. There needs to be something to define whether or not they're qualified and competent. And if you're in an academic setting, what you may find is that you have all these people who are on your staff, but they just, they pretty much just do clinic stuff. So they may not really do much in the hospital, but you may just end up having to keep them on. But still, if they haven't done anything at your facility and they have a full range of privileges, when they're recredentialed, then there needs to be some kind of a focused evaluation. For example, if you have a general surgeon who hasn't done any general surgery at your facility for 2 years, you can't just keep granting them privileges for general surgery without having some kind of documentation that they've either been working someplace else and doing a good job, that there's documentation, because you can't just keep granting them privileges if they're not doing those procedures. So it's all in how you document their experience and competency, and it may come down to where your medical staff has to be able to live with this determination of whether or not this person is competent and qualified, and they have to have enough information to be able to make a reasoned decision regarding whether or not someone should continue to have privileges. And you need to get something documented as far as competency or qualifications, or a process that is established so that if they haven't done anything for 2 years, if they do want to do some kind of a procedure, that there's an oversight for that.
All right, thank you, ma'am. Another question. Should a separate notification or form be included with the application requiring the provider's signature, notifying them upon initial appointment that the facility performs FPPE? And should there be a time period or number of cases noted on that form?
Oh, many hospitals do include, along with their initial appointment applications, they will give them a copy of their FPPE policy and procedure. It may be in, when they initially apply, or it may be when they, when they get their approval letter. Usually you will see some reference to FPPE and OPPE, just so that people know. You give them a copy of the bylaws. Nobody reads the bylaws. Now, they don't read the bylaws until they get in trouble, and then they want to know what the bylaws say. But no, hardly anybody reads the bylaws. So if there's certain elements that you need to emphasize, it's a good idea to do it, when they get their approval letter. This is to let you know that you have been granted medical staff appointment and privileges. You'll be subject to FPPE. The first 5 cases in each of these categories will be evaluated, and whatever the FPPE process is, and spell it out for them so that they know what's going to happen. You know, FPPE is something that should go on behind the scenes. It shouldn't affect that provider. The only time that provider should have, you know, unless that provider has to arrange for a proctor, then, you know, it should be all, it's usually going on in the background and doesn't really affect them too much. But they need to know what the requirements are for FPPE and also OPPE. They should be, the people that are working in the obstetrics department need to know these are the indicators we're going to be evaluating. And we are going to be getting a report card showing you what your indicators are and then how you compare to the other people. All of that being upfront and transparent is the best way of handling it.
Okay, thank you, ma'am. Next question. You mentioned using outside data as a supplemental data, but not to replace data. If you have a privilege such as sedation, but they have no volume but need it just in case, is that a rule from CME or JC, as we cannot find it?
There's no rule for specific to conscious sedation. There is a, if you look at the, as far as getting data from another organization to supplement or to evaluate, there is a Joint Commission standard that says that information from is collected from outside organizations if it's available, morbidity and mortality data if available, that you collect that from outside organizations. There is a standard that says that. As far as when I was speaking about, I was saying that you can get information from other facilities, but that won't substitute for your ongoing professional practice evaluation that you have to do at your facility. So what I was talking about was getting that data as part to evaluate as for recredentialing. So for OPPE, when you're recredentialing someone at your facility, you collect that data and you evaluate it within your facility. At the time you're recredentialing, your department chair, whoever's your approval, the people doing your approval would take a look at all that information that's been collected over the past 2 years with your OPPE, and they use that as part of their recommendation for continued privileges for the next recredentialing cycle. If there is no data, that's when you would want to go and get information from somewhere else where they're practitioners currently performing procedures. Or else you would want to get peer recommendations if you're a Joint Commission accredited facility. So there are some standards that do say that you evaluate this data. You know, it says data from a professional practice organization from another facility where they're currently working, if it's available, morbidity and mortality information, if available. CMS regulations do not speak to that. They just say that you have to evaluate the experience. So experience would be, you know, their you know, the procedures that they're performing.
All right, thank you, ma'am. Next question. Is it appropriate to charge a fee for a reappointment application?
Of course it is. Many facilities do that, and I've seen it done a number of ways. I've seen it done where everybody has to pay a reapplication fee. I've seen it done where people will charge a reapplication fee on a sliding scale and say, if you get your application back to us within 30 days, it's waived. That's as we use it as one way to get your recredentialing applications back right away. I've also seen people that hospitals that would have a fee for people who are only in certain staff categories. However your medical staff determines is appropriate is okay to do. So I've seen hospitals that had a requirement that if you were actively admitting patients and are consulting, you're actively sending your patients to the hospital, that the reappointment fee would be lower than for someone who doesn't maintain a certain volume. I've seen it related to categories. Active staff do not have to pay. Courtesy consulting do. So however it works, whatever works is fine. There's no problem with that. Your medical staff just determines what they feel is appropriate. Because if you have these people who are not admitting or attending or consulting, and none of their patients are ever coming to your facility, they're not even referring to hospitalists, all they are is a drain. They're a drain on your resources. So somebody, if they want the status of being on your medical staff, then they need to pay for that.
All right, thank you, ma'am. Probably our final question of the day is there ability to benchmark against national benchmarks?
There are a lot of benchmarks out there, national benchmarks out there. There's a government website. I'm trying to think of what the name of it is, but I can't remember. It's a government ARHQ or something like that, and they have a lot of different benchmarks out there. But if you search for, do a Google and look for benchmarks, you should be able to find some. There also the specialty associations do have some of those as well. They will, they will set minimum requirements for types of procedures that should be done, performed in order to maintain privileges. There are also a lot of benchmarks out there that that different specialty organizations have put out for complications for procedures and so forth. So you just have to go to the specialty organizations, or I think it's ARHQ. I'm not positive what the government one is.
All right, thank you, ma'am. That's about all the time we have today. I'm sorry for those whose questions we did not get to. I will definitely be sending those questions over to Ms. Kathy, and she can reach out to you in order to answer them. I would like to say again, thanks for joining us. Please make sure to join us next month. We have Ms. Kathy back to speak with us on June 8th. We will be announcing that on the website soon. Ms. Kathy, is there anything you'd like to say in closing?
Just that it's not ARHQ, it's AHRQ, Agency for Healthcare Research and Quality. It's ahrq.gov. And there's a research tab on there that does have some, and a data tab that you can look at, that you can see some benchmarks and quality data.
All right, thank you, ma'am. Well, again, thank you everyone for joining us. We hope you have a great rest of the day, and look forward to seeing y'all next month with Ms. Kathy.
All right, talk to you next month.
Thank y'all.
Okay, bye-bye.